Okay, good afternoon, and thank you for the invitation, Dr. Shahab. So, one of the most common comorbidities in heart failure is atrial fibrillation, and we know that atrial fibrillation and heart failure they have a bidirectional interaction, like fire and fury, because they share uh, the same risk factors, they share the same pathophysiology from neurohormonal activation, inflammatory mediators, hemodynamic changes, as well as structural changes, whether ischemic fibrosis and chamber dilatation. So, heart failure can beget atrial fibrillation, and atrial fibrillation begets heart failure. And there are some similar events that they can beget at the same time atrial fibrillation and heart failure. We know from the heart failure definition that we have heart failure with reduced EF less than 40, mid-range, or mildly reduced 40 to 50, and half PEF more than 50. And atrial fibrillation can occur and is prevalent in the three types of heart failure. Also, we have, when we discuss atrial fibrillation, we have to discuss chronic heart failure setting as well as acute heart failure setting. In this study from the nation's Swedish Heart Failure Registry, we can see the incidence of or the prevalence of atrial fibrillation is high, above 50% in reduced EF, and it can reach up to 65% in heart failure with preserved ejection fraction. And whether reduced, preserved, or mildly reduced, they have the same impact on heart failure, death, and as well as stroke incidence and TIA. We know from Atrial study that around 1 in 3 white patients develop atrial fibrillation, and 1 in 5 African American, as well as from the European side, from the Rotterdam study showed that the lifetime to develop heart failure in women is 29%, and in men around 33% by the age of up the age of 55. So AFib is prevalent in HFpEF, reaching between 25 and 39%, depending on the studies and cohorts. And AFib is prevalent in reduced EF, and the higher the NIHA class, the higher the prevalence. In patients with NIHA class 4, the prevalence can reach up to 50%. And any patient with heart failure has a 2 to 4-fold increase in developing atrial fibrillation. Not only that, but if a patient has already has a fib and he develops a new heart failure, the mortality increases. If he have a fib and he develops HFpEF, a new HFpEF, the mortality even is worse. But the most important thing, if these patients they have either heart failure with reduced EF or preserved EF, and they develop atrial fibrillation on top of the heart failure, the mortality is higher and higher. So mortality is significantly increased in heart failure patients who develop AFib. And this is why we have to think of prevention of AFib at this stage. Why AFib is a comorbidity in heart failure? Because it worsens symptoms. It has common symptoms and it worsens symptoms of heart failure. It's a reason for hospitalization and increased mortality. Anticoagulation in patients with AFib may be subject patient with heart failure to increase in bleeding. There's always a challenge, rate control, and if need, especially in heart failure with reduced ejection fraction, because we need to decrease heart rate, and the controversy of rhythm versus rate control, who benefit from ablation. So it's not only a challenge for the physician, but also an additional obstacle for the heart failure patient when they develop atrial fibrillation. And the management of patients with concomitant heart failure and atrial fibrillation, first we have to identify and treat the possible causes that triggers atrial fibrillation, like hyperthyroidism, anemia, infection, management of heart failure per se. The patient has to be on the optimal therapy with heart failure, especially reduced with the 4 triple therapy, prevention of embolic events with anticoagulation, and then comes rate and rhythm control. This algorithm from the heart failure 2020 guidelines. So management of heart failure starts with the 4 pillars, but also we have to do some selection or personalized therapy depending on the conditions the patient is having. And one of them is atrial fibrillation. And we have, in addition to class 1 in green, to have oral anticoagulation, we have to think of rate control and rhythm control in these patients. This is algorithm from the ASC 2020 guidelines. I will go in details. So first, what is the management of atrial fibrillation in patients with HFrEF? First thing is anticoagulation to prevent embolic stroke. And long-term treatment with oral anticoagulation is a class 1 indication in CHAD bus score more than 2 in men and more than 3 in women. And it's a class 2A indication in score in CHAD score 1. So even in CHAD, they have only heart failure and they develop a fib with no other risk factors. It is a 2A indication to give oral anticoagulant. What oral anticoagulant? It's recommended and preferable to have dual oral new oral anticoagulants compared to vitamin K antagonists. Second thing, we have to treat the triggers. Look at the triggers and treat them. Whether infection, fever, hyperthyroidism, anemia, ischemia, we have to treat the trigger. And then we have to optimize the HFrEF therapy with the quadruple therapy, ACE-ARNI, beta blockers, MRA, and SGLT2, and risk profile these patients and treat accordingly. If the patient then is hemodynamically unstable, we have to go with rhythm control and electrical cardioversion. Urgent electrical cardioversion is recommended in the setting of acute worsening heart failure and in patients with rapid ventricular rate with hemodynamic instability like hypotension. Cardioversion may be considered as a class 2B indication in stable patients whose symptoms are related to heart failure. If after electrical cardioversion they go into sinus rhythm, then we have to think of rhythm controlling these patients with either medications like amiodarone, or we have to think of pulmonary vein isolation and ablation in these patients. If electrical cardioversion doesn't work and maintain the patient in sinus rhythm for a long time, then the decision is rate control. And to rate control these patients, we have different medications and different settings. So beta blockers is the first choice in HFrEF patients, in stable patients, not in acute decompensation. If they are in acute decompensation, IV amiodarone can be used at the beginning for rate controlling these patients, and plus minus digoxin, because digoxin alone will not help in fast heart rate when there is increase in sympathetic activity in the acute phase of these patients. So this is for hemodynamically unstable patients. What about heart failure hemodynamically stable patients? So we have a HFrEF patient and hemodynamic stable. So what is it, rate or rhythm control? This is a summary of the rate versus rhythm control of different trials in patients with AFib and heart failure with reduced ejection fraction. And we can see that in the diamond race, AFFIRM, which is the most widely known, AF, CHF, and CAFE, that either there is no effect on mortality or rate control is not inferior to rhythm control in these patients. So either it's not inferior and there is no effect on mortality, whether we use the rate or rhythm control. So we can think, okay, we can go with the rate or rhythm control in these patients. To go with the rate control, as I told you, we have different drugs that can be used in heart failure with reduced ejection fraction. Beta blockers as a class 2 indication, and digoxin should be considered when the ventricular rate remains high on beta blockers or there is contraindication to beta blockers. It's a class 2A indication. If symptom improvement, that's okay. If symptoms don't improve, then we have to think of other medications versus other modalities of treatment. In the acute setting, IV amiodarone can be used if we are not able to use beta blockers for rate control in these patients. So if symptoms improve, then we have to follow up the patients. But if the patient is still symptomatic, we have to think of rhythm control. Rhythm control in these patients, it's either electrical cardioversion, pulmonary vein ablation, or giving them intravenous amiodarone. What about atrial fibrillation catheter ablation? It is a class 2 indication in cases of a clear association between AFib, whether paroxysmal or persistent, and worsening heart failure. So if this is the cause, or this is the cause of the symptoms, then it's a class 2 indication to perform atrial ablation on these patients. Otherwise, we have to go into either a transesophageal guided electrical cardioversion if we are not sure about oral anticoagulation on this patient, or give them amiodarone, load them with amiodarone, even though the chance of recovery compared to the chance of reversion to sinus rhythm is sometimes low in these patients. If the patient stays in atrial fibrillation with all this therapy, and they are still symptomatic, then the only treatment that we have to think of is rate controlling them with AV nodal ablation and implanting a CRT device to these patients. CRT with AV nodal ablation because they have heart failure with reduced ejection fraction, and this will help in improving symptoms, rate controlling, as well as there is a chance to improve LV in these patients. This is a summary of the AFib ablation trials in heart failure with reduced ejection fraction. In most cases, from the Papa CHF to the Kessel AF, all these patients either showed superiority or non-inferiority, and most of them they showed either reduction or improvement in ejection fraction, improvement in oxygen VO2, peak VO2, and improvement in symptoms, and a reduction in the time that the patients are in AFib. And in a meta-analysis, the chance of AFib recurrence favors more ablation. Heart failure hospitalization is reduced more if we choose the ablation arm in HFrEF patients. Change in EF favors ablation, as well as all-cause mortality also in favor of ablation. And this is why in 2020, AFib guidelines from the ASC revealed that or mentioned that paroxysmal AFib or persistent AFib with heart failure and reduced ejection fraction, it's a choice for the patient to choose after explaining to them either go with the catheter ablation or the antiarrhythmic drug for rhythm control. But it was stated that it's a class 1 after all these studies to have catheter ablation for rhythm control in these patients. And if drugs fail, then we have to go into ablation as a class 2A indication. So HFrEF patient with symptomatic AFib, the first choice is catheter ablation to improve EF, reduce mortality, reduce hospitalization, and reduce occurrence of atrial fibrillation. But the choice of atrial fibrillation with concomitant heart failure with reduced ejection fraction depends on several factors. Because sometimes rhythm is beneficial in some, and catheter ablation is beneficial in some, while rate control is more needed in other conditions and preferred in other conditions. So if the patient is suspected to have tachy-induced cardiomyopathy and he has fewer comorbidities and limited left atrial dilatation, it's mild to moderate, it's not severe, he's young, with symptomatic AFib, paroxysmal or persistent, more benefit with rhythm control. While if the patient is end-stage heart failure, NIHA class 4, severely dilated left atrium, long-standing atrial fibrillation, and the failure of previous rhythm control treatment, then the patient will benefit from rhythm control. And likely to benefit from catheter ablation are these patients with AFib-mediated cardiomyopathy, NIHA class 1 or 2, no significant ventricular scar on LGE, paroxysmal and persistent AFib, and younger age at the time of ablation. Thank you.